talking about the concept of DARE, so debridement and implant retention, because as Volker very nicely demonstrated in some of his early slides, bacteria very much like multiplying up on implants, on foreign material, to an extent that boggles the mind. So anytime there is an infection around an implant, the easy thing to do is to take it out. It's certainly easier to control the infection that way, and certainly logically. The trouble with that is that then gives you a bigger reconstructive challenge. And you know, from the fake joint world, the concept of keeping implants in place and trying to debride them, retain the implant, and avoid that complex reconstruction down the line is certainly something that is popular and is appropriate in certain settings. So all we've got is a few cases here. We might only get through one or two of them in time, but it's really to open it up for discussion as to, you know, what thought processes go into whether we're going to try and keep everything in, or whether we're going to go all out to remove implants and start from scratch. And I'm actually starting with some arthroplasty. So this is a patient that we treated a few years ago now. So this was him when he was 37, fit and healthy guy. He was a manual labourer, but he had a very arthritic ankle. And so in 2012, a hospital a bit north of here did an ankle replacement, which he was very happy with, and he kept on working and kept on in his physical manual job, and was delighted for about 5 years or so, maybe 6 years. And then he started getting increasing pain that was stopping him working again. And so by 2019, he ended up with this situation where the original prosthesis was starting to come loose. There was some osteolysis around it. There'd never been any sign of infection at this point. This had been a well-functioning ankle replacement with no wound problems, but it was wearing out at that stage. The decision by our colleagues in the other centre at that point was to go for a revision ankle replacement, which in itself, in this age group, obviously, is somewhat controversial. But he went ahead with that procedure. They were happy with how it went intraoperatively. But unfortunately, he was referred to us. This is about 6 weeks later. So he's got this new ankle replacement in there. There's more bone that's been resected to put it in, but he's had this breakdown of this anterior wound. There's exposed tendon. He wasn't actually referred to our orthopaedic department. He was referred to plastics with the question, could you put a skin graft on this? Because the foot and ankle guys were very much keen to keep this in. Our plastic surgeons that then involved our wider MDT, and this is where this discussion stemmed from. So, you know, this is a relatively fit and healthy gentleman. He wants to remain active. His previous ankle replacement had been functioning very, very well and giving him a good range of motion. He was actually able to move this ankle, even with the exposed tibialis anterior, reasonably well. So as a joint, it was functioning reasonably well. And he was keen to maintain that level of function from all he'd been told prior to this. The other concern that we had with removing this implant and doing a multi-stage revision is just the amount of bone loss that would be inherent in it. So he's got there was a previous keel there, and this area has now been bone grafted. So there could potentially be quite a large area of bony resection. So there was discussion within our unit as to whether a DARE would be suitable for this. The plastic surgeons said the only reconstructive option for the soft tissues would be a free flap. He had good vessels and they were prepared to do a free flap, but the question was what we would do underneath that. Will, do you want to talk about why you wouldn't? And then we're going to open up to the floor to see what some of our colleagues think.
So, does anyone know? So, what are your kind of predictors of success in a DARE? Anyone want to volunteer?
Over there.
Yes.
Got a single pathogen.
Yeah, so sensitive, yeah, single sensitive organism, excellent. We don't know that yet. Yeah, so ideally short duration of infection. Yeah, so good quality soft tissues, ideally amenable to primary closure. Sorry? Yeah, so you need, yeah, so stability and well-fixed implant indeed. And so have we got, how many of those have we, and the other thing, there's another important thing, the host themselves as well. So have you got a kind of a good host? So what do we think in this situation? How are we looking?
I think it was about 6 weeks.
This is 6
ish.
weeks on
7 weeks maybe.
on a background of a failing previous implant they'd been in for 8 or 9 years.
Samples from that was negative at the time of revision.
Yes,
Yeah.
Negative at revision, yeah.
Yeah. So host, from what we know, pretty reasonable, no significant medical problems. Soft tissues. Yeah, not great at the moment. We've heard we do have options for immediate coverage with a free flap. What's the big problem with a free flap and when you're trying to do a DAIR? What are you worried about?
Going back in.
Exactly, yeah. So if you're putting a free flap on, you don't really want to go under, and especially no time soon. So if you do have any further problems with infection, then you're potentially, you're not only causing problems to the local area, you're basically damaging another part of the body potentially for without any significant benefit. So we talked about stability. Does this look stable? I mean, it looks like we're already getting loosening, and it's only been a matter of weeks already, so it's not looking great from that point of view. And in terms of organisms, so we don't have a definite bug to treat either at this stage. So I would say it's not looking amazing for a DAIR in this case. What?
Just going to direct a question to our foot and ankle colleagues at the front. I mean, do you guys have much experience of DAIR post ankle replacement? Because it's obviously a smaller niche than knee and hip.
I was just saying, no, the DAIR is really only just for the very, very early ones. So if you've got a really well-fixed implant that you know is otherwise doing well and you're desperate to get that wound closed, then you might DAIR at that point. But I think for that revision there, it's in varus. It's almost certainly loose, lots of dead stuff in it. Absolutely not.
Fair enough. Any from that table differing on this? Volker, is there much experience in your unit of infected ankle replacements? This being a foot and ankle day, I thought I would throw one of these in.
Yes, yeah.
This is a very nice case that shows the specific problems with ankle replacement when they get infected, because you often have severe soft tissue problems, which is not the case for the hips and for the knees, but for the ankles. And I've currently a similar case in my unit. But in this case, I mean, you have real bad prognostic factors, which is the severe soft tissue situation. It is, if you have a soft tissue, like a situation like this, you always have a polymicrobial infection. This is not a single microorganism anymore. And also the bone situation does not look so nicely, but I mean, in general, it's a young patient. He has good vessels. It's 6 weeks. Because what is your alternative? Your alternative is that you do an ankle fusion with the free flap. So I would go for a discussion with the patient. I would say, okay, the chances are not very high. The chances might be around 50 or even 40% that DAIR works. But I think in this case, I would try to do it with a free flap, one surgery. And even if it gets reinfected, I think in this situation, because the patient has good general health conditions, the flap could be saved for a second ankle fusion procedure.
When you quote 40 or 50% success, What do you sort of mean by that? Is that over a certain period of time?
Yeah, I mean, the 40 to 50% of success would mean that we could control the infection. I think revision ankle joint replacement will not last for 20 years. So my goal would be to control the infection and to get to a comparable result like an aseptic revision procedure.
Excellent.
Go for it.
So I didn't appreciate it was only 6 weeks post-op, but I have had one of these in my own experience where the wound was fine at week 2, week 3 a little bit open, week 4 started to open. It's like a slightly ischemic leg, I suspect, but he ended up with a tib Anton show, which we removed as a sort of an initial debridement and closed the plastics, and the implant was never affected because it had all healed underneath. So I would, in this case, want to know, is that implant infected? I think we just made an assumption it is because it's a broken wound. And I wouldn't say definitely it is.
I mean, there is no way you know that. You can make an assumption. If the wound like this, you presume, or and you take a guess.
Yeah, I'm still following this guy 10 years later. So I know it wasn't infected, but I'd aspirate it as a minimum. You can do things like that, can't you?
So it's a fair point, and I think that it's quite a nice case just for demonstrating the difficulties in the thought processes here, because there's no easy option for this guy. He's young, he wants to continue functioning, he wants to continue working. We don't want to burn any bridges. I appreciate that, if we do a free flap and we have a recurrence of infection, we would hope we can salvage the same free flap to then fuse him. But I think there were concerns from the plastics side that they could potentially be doing a free flap that then is wasted in inverted commas. So we discussed this at length in our MDT, and it's the nice thing about having that process. It's not just this is very much not just a one-person decision. And discuss with the patient as well. I think when we quoted the likely high failure rates from Dare, he ultimately decided he would want to go on to have an ankle fusion. When we debrided him, I've cut out my debridement slides. That's a shame. There was a very significant bone defect. By the time you taken out the implant and debrided all the frankly infected, there was interoperance. It definitely was infected. By the time you debrided all that tissue, we had quite a significant area of bone loss. We ended up partially shortening him on table and finishing the compression of the fusion gradually using a circular frame. And he had a free gracilis, I think that was, flap that was plumbed into his anterior tibial. It all went on to heal very, very nicely, actually, from a soft tissue point of view. Do I have his micro on the next slide? All of his deep samples were positive. There was 2 bugs. It was Enterococcus and something else. I may have it on there. No, I don't have it on there. So this was definitely infected. He went on to, so this was, in fact, to tell you what, he was actually recruited into Solario from memory now. So he actually was in the short arm. So he had only a week's worth of systemic antibiotics in addition to the stimulant that we put in, which had vancomycin and gentamicin in it. The organisms were sensitive to that. We did proximal lengthening using the frame because we have the opportunity to do that with our external devices, which is quite nice. So we could equalize his leg lengths. He went on to heal very, very, very nicely. He's got a good functional fused ankle. His alignment on his long leg views looks quite nice. He is walking very well. Is fairly happy with it. Obviously, he's lost that ankle movement, but he's back in his manual job. Hopefully, this will last him for the remainder of his days. Is it the right thing? As I said, could we have got away with doing a Dare and given him another 5 years of ankle movement? I don't know, but I think at that point he probably would have ended up like this anyway. He was fairly happy, but yeah, it's sort of an interesting thought I thought to start us off with. So that's a fairly kind of classical dare discussion for a joint replacement. I think we'll let Will do the next one, which we verge into more craziness at this point. But
I wanted to ask James how his
Patient without Tibant managed with their ankle movement as compared to a fusion patient.
I did an EHL transfer afterwards, which worked really well. And the reason I saw him recently is because I kind of put EHB onto the toe, which was working, that failed, and he ended up with this floppy toe. So I just fused his big toe joint. That's how I know it's still in there and it's all right.
Fusion than an ankle fusion.
Yeah, I imagine.
yeah, I guess so.
And would any of you manage that without a frame? That similar situation? Any non-framers would have done that differently?
Yeah, we don't have frames for such exciting things in our hospitals, so they just get a big blown block removed, temporary spacer, wait for all the microbes to come in, and then if we're reasonably happy, then we would go with like a 4D spacer frame, you know, these 3D printed frames, cages, should I say. Otherwise, no, it's a phone call to Prof. Sharma to say, can you do it, please?
Because a lot of places, when they do ankle fusion for internal fixation, you have to do two stages. Stage one, you do the stage one, you clear the infection. Stage one, you'll clear the infection temporalizingly for a few weeks, 6 weeks, whatever it is, and with a bone block or a cement spacer, and then you go and do a second stage. That's most of the place will do internal. No?
Hi, I was going to ask, so on that note, my question was, could you have done a two-stage? The first stage being what you did, clearing the infection, etc., and then the second stage, if he so wished and you had the discussion about it, put in, for example, the longer stem ankle replacement, like the Envision, you know, which has the longer block that goes up the tibia, etc. Would that have been an option, preserve mobility, and also, you know, help?
So James will probably be able to answer about the ankle revisions because they don't have a long-term outcomes, or they don't last as long as hip and knees. So that's one of the concerns, especially in young patients. But
Yeah, it's a good question. If you can guarantee you've cleared all your infection and you want to go down building it upwards, it's called an inbone, I think is the one you're thinking of, isn't it? Yes, it can be built up to that. Your talus, there are people experimenting, because often a lot of talus is dissolved away or destroyed, is either partial or total talar replacements with that. I'd look at a guy who's 37 years old and go nowhere near any of that stuff. It's all pretty experimental and people don't really know. And if you ever look at people who've either had a primary or a secondary, they're all pretty bloody stiff anyway. It's not like their ankle moves like normal. So you kind of, are you asking an awful lot of an implant to do not very much? So I typically go down the fusion route, would be my preferred option.
Right.
Okay, so the next one's probably a bit more unusual, to say the least, but we'll go through, and again, it's a case of sticking to principles. So this is a man who was referred over about a year ago to the bone infection unit here in Hull from a local district general hospital with, at first kind of glance, a 6-week history of wrist pain and problems with a confirmed infection. He's 61, he normally is independent, he's right-handed, so it's his dominant side, but he does have quite a few medical problems, diabetes, kidney problems, ischemic heart disease, heart failure to a degree, that doesn't massively affect his mobility. Previous alcohol excess with his liver affected, but he's a non-smoker at least. When we get to the actual what's happened, it gets a bit more unusual. So he became unwell on holiday, returned to the UK, and when he arrived in the UK, he was very unwell and was admitted to ICU with suspected right wrist septic arthritis. He had multiple bugs in his blood cultures, but had a number of MRIs sequentially without any surgical intervention. And all these MRIs reportedly said the wrist itself was okay. It looks like a bad soft tissue infection, cellulitis, which was responsible. So this went on for about 6 weeks until he eventually had a wrist washout, which grew the same bugs. but it was a straightforward open washout he had at that stage. Was still grumbling along for a couple of weeks more, and then he developed this wrist drop without sort of sensory changes, just a wrist drop. Had another MRI. Now this time, the MRI was reported as widespread osteomyelitis and big collections around the wrist. And at that point, he was referred across to us in Hull. And again, it's the same thing. It's up to this point, probably the sort of what we'd agree would be the standard things you'd be looking for in treatment of these suspected bone infections probably hadn't been stuck to in a way, but sticking to them, you can get there. So by the time he came across, this was his wrist, not looking too good, and he basically went straight for a debridement, and all his carpus was dead, and all his extensors were dead as well. So it was a combined orthoplastics debridement as a first stage. So he had a total carpectomy. He had a big dorsal soft tissue defect by the end of the debridement with his extensors gone. He was placed into an X-fix with some local antibiotics as a first stage. And then the planning for what to do next began, which was, as you can imagine, fairly complicated. But it involved plastic surgeons, max fac surgeons, orthopedics, obviously microbiology, the rest of the team. And he ended up going for a reconstruction a few weeks later, having had 3D printed jigs for mapping out, planning for free fibular grafts, fasciocutaneous grafts, as a stage procedure once the infection was as clear as we thought it could be. So he ended up having these bone grafts, fasciocutaneous grafts, plus extra BTM for areas where the grafts couldn't cover. And then all stabilized with some plates internally on the dorsum of the wrist. However, 2 weeks later, wounds not looking good and starting to break down. So what are our options at this stage?
Someone's allowed to say the very obvious one.
Okay, who have we got? Here's Hamza. Do you want to give it a go?
I think, yeah, the obvious one is the obvious one is amputation.
Yeah, fair enough. Yeah, so that's definitely the kind of, I suppose, radical option for, but yeah, radical debridement.
Yes.
Removing the source. Yeah. So he's not got any active, he's not got any wrist movement, obviously, no active finger extension, thumb extension.
So his flexors at that stage were intact and had some function. It was very stiff.
And he does have
he has a sensate perfused hand.
And he's still perfused in the hand as well.
So, like you were saying in the leaky wound thing, not all wound breakdown, not all leaky wounds are necessarily infective. So you could monitor it and see how it goes. You could try and readdress the soft tissue, regraft the soft tissue.
Yep.
Put a wrap on it, hope for the best.
Yeah, cross your fingers. That's
That
always
for
an
the rest of
option.
his days.
Maybe not the best option, but always an option.
So I'll offer some more context. This is one of my cases. So, and as Will was putting these slides together last night, I realised quite how ridiculous I was being attempting this. He has a lot of comorbidities. He doesn't look like a guy with that many comorbidities. He looks better than he sounds, but the issue that we had intraoperatively doing the free fibula was with getting flow into the flap. So that the surgeons, the plastic surgeons, had to have multiple attempts to get the anastomosis. It kept clotting off. And so it was probably avascular for quite a long time. So actually, what you said is in a way right, in that not all wound breakdowns are infected. And actually, what started to happen was he was developing necrosis of the skin paddle of the free flap. So actually, I think it had been ischemic for too long, probably. And yeah, the skin was starting to die at this stage around the edges.
Yeah. But as you've said, I mean, exactly that. So we don't have a definite diagnosis of what's happened here. We've got a strong suspicion. You could monitor, you could aim to suppress, just wash it out. Obviously, this is a talk about DARES. Implant exchange. Implant exchange is difficult at this stage because of what's gone on, how much fixation you're able to get. And almost, I mean, it is a graft, it's a vascularized graft, but your bone is almost acting like an implant in itself, potentially at this stage. Your new grafts. And amputation, as you said, definitely is always on the table right from the start, which this patient didn't want. But again, it's sticking to the same principles as we've talked about before. We want to find out if this is infection. We want to ideally take more samples now the wound's breaking down. We need to get that soft tissue envelope restored again. And any infection there is, we want to do our best to debride it. We've got to maintain stability one way or another. And we do this again through the MDT. So so the next step was actually a DARE. So he's had he had it debrided. He had that dorsal wound which was breaking down debrided. Soft tissue options get more and more difficult, so he's ended up with quite an old school technique in an abdominal flap. So he ended up with his arm inside his abdomen under the fat layer for about 3-4 weeks before it was removed and then grafted. Yeah, well, I'm no plastic surgeon. I don't know the ins and outs, but I think it's kind of based, as far as I'm aware, of pretty much the original transferred flap was like sort of I think it was like the sort of during the Renaissance in Venice with people who used to lose their noses because of syphilis, and they used to essentially transfer tissue from the upper arm, so they'd walk around with their arm on their nose for a few weeks before the tissue took to the area. And it's essentially a similar process here. You put your area denuded.
Before the free flaps came, until 60s, 70s, and I think 80s, we started free flaps. Before that, you often will have people walking with one TB over another. Or when there's a walking means on the bed for 3 weeks. So when the graft is taken over, then they cut it from other leg. So this was a common practice in orthopedics, free tissue from other leg, because we did not have the microvascular techniques. In 80s when it started, things have suddenly changed, and now we are doing even not microvascular, what is called that, even tiny vessels which you can't even see with microscope kind of thing. What do you call, there's something else. There's a name, Japanese are doing quite a lot of those these days. So, supramicrovascular.
Even more micro, yes. I mean, the concept here is that, so you're lifting a rectangle of skin, but leaving one side attached. So here you're lifting up a flap of skin from the abdomen. You're relying on the blood flow from that attached edge, keeping this skin perfused for a period while you stick the arm into it effectively. Over time, you will get new vessels growing from the arm into that tissue flap. And after a period, when the plastic surgeons are happy that process has occurred, they can then divide the skin from the abdomen, skin graft the area where they've lifted it, and hopefully that skin survives at that point because it's grown new vessels. So it's got that original blood supply coming from the abdomen for a period of sort of 4 to 6 weeks before they start thinking about dividing it.
So. But essentially, in this situation, I think you can look down and see what are your predictors of success with a DARE, and unfortunately, he doesn't have a great chance of success in some of the ways because he's as a host, he's not physiologically, he's not amazing. Stability-wise, we're pretty good, but we don't really have too many other fixation options for if we do remove the metalwork that's in there. Timescale-wise, he's had a problem which has been going on for a while, but acutely it's actually still fairly early, so that's in our favour. We do know what bugs are there, so it's not amazing, but I think the kind of grim reality is often it's You just have to do the best option, take the best option available, even if it's not a fantastic option. And again, it's about discussing with the patient, making sure they're aware of their options, what the consequences may or may not be, and giving them the chance to make an informed decision. So he ended up, as often with these situations, he did pretty well for a while. He had about 7 months where everything healed up. His hand was never hugely functional. He was able to grip to a degree. He mainly used it as a post to push against with the other hand. So things like washing up he could still do with this hand, which he found a benefit to him, and he found it worthwhile. But about 7 months later, the volar wound broke down. He ended up being seen again locally, and I think it was a bit of a delay to coming back to see the plastic surgeons here. But at that stage, he had dorsal and volar wounds that opened up again. Systemically, he wasn't unwell. But at that stage, the graft had actually united. So we managed to, by doing that DARE, we managed to get to the point where we've achieved, he's got sufficient stability without needing metal work in situ for fixation. So this was, just beginning of May. He went on to have another debridement and local antibiotics. Still not amazing. He's still got some oozing, but he remains well in himself and still wants to keep his hand. So that's where we're at currently. Okay.
I think, go ahead, Volker, yeah.
Excellent case. Just one comment. 95% of all infections of the musculoskeletal system are not emergency cases. There are only 2 exceptions. And one exception is if the patient is septic. This can occur after periprosthetic joint infection, fracture-related infection. And the second emergency is a septic arthritis. And I think this is one of the key learnings of this case. If I got that correctly, he was diagnosed with a septic arthritis of his wrist joint early April. And then he had several MRIs, which is useless. The treatment for a septic arthritis is an emergency joint lavage. And he had this treatment only 6 weeks later. And then he had the typical consequences of a delayed treatment of a septic arthritis, which is a massive joint restriction, which cannot be saved anymore. And therefore, a septic arthritis is an emergency case.
Yeah, I think that's a very fair point. And we never really got to the bottom of why there was that delay in this other hospital. It was always quite confusing as to why it had been sat on for that.
Too sick to operate, but
well, there is a bit of that, but they're too sick because they haven't washed out the septic arthritis. I think we're going to have to probably jump. We won't do any more cases on this because we want to do the smaller case discussions, or we'll run out of time, won't we? Any questions about this session? Hamza, did you want to ask something?
In terms of if limb salvage wasn't a possibility, I think we kind of know a lot more about lower limb prostheses and things like that, and upper limb prostheses. What kind of are the options available? Are they kind of in terms of function as well? What level can they be?
So it's a fair question. I'm probably not the best person to answer it, to be honest, because it's our colleagues in the prosthetics department that deal with those. We do a lot fewer upper limb prostheses. They do have some functional ones. I think the benefit that we felt this guy was at least getting is that it's still a sensate hand. He has a little bit of flexion, not very much, and so for using in conjunction with his good hand, he certainly is finding it useful to have sort of a sensate end organ effectively. I don't think an upper limb prosthesis would have given him anything better. Whether it had been that much worse is an open subject for debate. And reflecting on this case, this is a case of we were extremely ambitious and it doesn't always work. But I think this was the patient was informed and was keen to at least give it a try.